So welcome everyone to our focused lecture series 4. And today the topic is ectopic pregnancy. And I'll be completing this in 3 parts. First is very basic, which I'll be covering today. Tomorrow, a more advanced like ultrasonological features, discriminatory zones, exact criteria for medical management, what is changing in medical management, and day after tomorrow, or maybe after that, I'll be discussing the recent updates about ectopic pregnancy, as it is very important for postgraduates and all the practitioners to know what has happened recently in the course of management of ectopic pregnancy. So here is a case uh, that was done as a presentation. It was suspected as a case of PID, but it turned out to be ectopic pregnancy. Now, the first thing over here is very evident from the topic itself, that the first differential of ectopic pregnancy can be pelvic inflammatory disease. So let's move further and see what has happened. Yes. So a young lady presented to the OPD with complaint of lower abdominal pain, spotting per vaginum from day 7 of the cycle. She menstruated for one day, then her menstruation stopped. She presumed that she scantily menstruated during this cycle, but then from 7th day onwards, she started having slight spotting. She also had fever for the last 10 days, and she presumed this also, that she was taking some antipyretics, that her menstruation must have been disturbed because of this. Otherwise, she had fairly regular cycles, which were never associated with any kind of dysmenorrhea or heavy bleeding. And she was married for 1.5 years. There was non-consanguinity in marriage, but she was trying for conception and was not using any contraception. There was no history of diabetes, hypertension, bronchial asthma, epilepsy, or thyroid disorder. Neither was there any history of previous surgeries, especially pelvic surgeries, and this is important in case of ectopic pregnancy. Apart from this, bowel bladder habits were normal and family history was also non-significant. Now, when we come to examination, she was sitting anxiously and she was continuously putting her hand over the right side of her lower abdomen. She was febrile to touch also, but hydration status was fair. There was pallor, but no gross edema or anything like that. Pulse, blood pressure were also fine, and systemic examination were also normal. On per abdomen examination, it was soft, but there was tenderness in right iliac fossa. So now second thing or second differential diagnosis in such a case is appendicitis, especially if the pain is persistent and in the right iliac fossa. When per vaginum examination was done, cervix was fine, uterus was retroverted in normal size, but all the fornices were very tender. So a diagnosis of ectopic pregnancy, query PID was made, and further investigations were sent. So to UGs who must be watching this, what is the first test that we do to rule out ectopic pregnancy and to differentiate it from a case of pelvic inflammatory disease? You can post your answers in chat box. So first test that was done was a urine pregnancy test, which was faintly positive. And that is how it was differentiated that maybe we are dealing with a case of ectopic pregnancy rather than that of a case of PID or appendicitis. So ultrasound was ordered, and in ultrasound, a heterogeneous lesion of 5 by 3 centimeter was present in left adnexa, and which was very close to left ovary. Nothing was present in right side, but patient has had pain surprisingly towards the right side of the abdomen only. Further, a ring lesion of around 2 by 2 centimeter with thick hyperechoic rim and showing peripheral vascularity was also visualized. Beta SCG was also sent and obtained, and it was 670.
Recording in progress.
So on laparoscopy, she was taken up for laparoscopy. I'll discuss the details later on. It was left ischemic pregnancy, and it was extracted, and finally a diagnosis of ectopic pregnancy was made. So what is actually ectopic pregnancy? Very, very basic. If my students are here, they must be ready with the answers on their tongue tip. So actually an ectopic pregnancy is a complication of pregnancy in which pregnancy implants outside the uterine cavity. Usually they are not only viable but are also very dangerous for the mother, as if at all they are rupturing, they may lead to massive internal bleeding and hemoperitoneum. Quite many lives were lost earlier to this intraperitoneal bleeding, but thankfully nowadays we are detecting them and managing them earlier, and morbidity and mortality is quite reduced nowadays. So when we talk of ectopic pregnancy, these are the sites. Just to remember, the commonest site is fallopian tube. In the fallopian tube, ampullary portion is having the maximum share of ectopic pregnancy, that is 75 to 78%, followed by ischemic area accounting for 10 to 15%. Then comes fimbrial part, which is around 5%. And in this fallopian tube and this area, cornal pregnancy is carrying an incidence of just 2%. So in fallopian tube area, it is the cornal pregnancy which is least likely to happen. Then coming outside the fallopian tube, what are the other sites? Common site is again ovarian, because egg is released from here, sperm is coming from here. If it is not traveling inside, it tends to implant on the ovary. Again, it is a very dangerous kind of ectopic pregnancy. Apart from this, abdominal pregnancy is very rare, less than 1% of the incidence. Caesarean scar pregnancy, although it is responsible for 1% presently, but incidence is rapidly increasing. As we can see, like in 1 year, we saw quite many cases of caesarean scar ectopics. And cervical pregnancy in the region of cervix is again 1%, very rare. So implantation sites, precisely, if it is happening in uterine, it can happen in cervical area or caesarean scar area, otherwise angular and cornual pregnancy. Now for postgraduates, tomorrow we will be discussing the differentiation of angular and cornual pregnancy. And if you are interested, you can go back and read about angular and cornual pregnancy and can tell me tomorrow which of these pregnancy is actually ectopic pregnancy, other one is not an ectopic pregnancy. When we come to extrauterine site, as discussed just now, tubal area is the commonest, followed by ovarian and abdominal, which is having primary abdominal as the least percentage or least share in ectopic pregnancy. Otherwise, secondary pregnancy, secondary abdominal pregnancies we have seen, and intraperitoneal or extraperitoneal broad ligament, we see just case reports in literature. In tubal pregnancy, ampulla, isthmus, infundibulum, and interstitial and cornual pregnancy, as we have just learned, and ampulla becomes the commonest site. And this is a common question asked in your PG entrance examination also. What is the commonest site? What is the incidence of a scar ectopic? What is the incidence of primary or secondary abdominal pregnancy? So you can just have an overview or just a knowledge that fallopian tube is the commonest. In fallopian tube, ampullary area is the commonest. And nowadays we can see cervical and caesarean in increased frequency. So what causes ectopic? Basically, any factor that causes delayed transport of the fertilized ovum through the tube can predispose.
Gynae depends on sex. How can I avoid it? So,
okay. So any factor that causes delayed transport of the fertilized ovum through the tube can predispose for an ectopic gestation. Fallopian tubes sometimes may favor implantation in the tubal mucosa itself, thus giving rise to tubal ectopic pregnancy. And there are 3 points which you must remember where fallopian tube is favoring implantation inside herself. Now, these factors may be either congenital or acquired. So when we talk of congenital or background factors which are present in a tube which can lead to ectopic pregnancy, it is tubal hypoplasia. ट्यूब सही से जनरेट नहीं हुआ, extreme tortuosity of the fallopian tubes and extreme lengths of fallopian tubes. And if obstetricians are watching this, they will agree with me that whenever we operate any case of ectopic pregnancy, we usually comment कि yes, this was a long tube and thus इसमें तो ectopic होना ही था. Then congenital diverticuli of the fallopian tube, where there are ingrown pouches in fallopian tube and ectopic-fertilized ovum is entrapped in those pouches. Presence of accessory ostia favoring stoppage of blockade at fimbrial end. Sometimes partial stenosis due to damage of tubal mucosa or partial stenosis due to congenital malformation, extreme elongation, intramural polyps, again obstructing the tubal mucosa, and these conditions entrap the ovum on its way. Acquired causes, a background risk factor for having ectopic pregnancies increased at maternal age. If a patient is having active or past history of pelvic inflammatory disease, she is predisposed 6 to 10 times more than normal population to have an ectopic pregnancy. Where tubal ligation or sterilization procedure was done, then if at all there is stenotic and there is a small fistula kind of cavity forming at the cornual end, sperm can exit through it, have fertilization with the ovum and get implanted inside the fallopian tube, thus causing ectopic pregnancy. Contraception failure leads to ectopic pregnancy. Now, we must not be under the impression that using contraception causes ectopic pregnancy. There is a basic difference. वो difference क्या है? Overall, contraception usage से pregnancy prevent होगी. और वो every kind of pregnancy will be less in number when there is contraception use. But whenever there is failure of this contraception, instead of intrauterine pregnancy, there are more chances of ectopic pregnancy. The reason is, especially with the levonorgestrel, with progesterone containing contraceptive agent, they inhibit and decrease tubal motility. And whenever there is inhibited or decreased tubal motility, this fertilized ovum will be entrapped inside the fallopian tube and will not be traveling through its entire length to get implanted on day 4 in the intrauterine cavity. Then previous ectopic pregnancy is a strong independent risk factor for having ectopic in current gestation also, and one should be really alert. Tubal reconstructive surgery like recanalization, fimbrioplasty is again a risk factor for having ectopic pregnancy, and having a history of infertility or subfertility, and we are treating them, and so we quite often see whenever we are doing ovulation induction and there was a tubal disease which was undiagnosed or we cannot diagnose it, then it may lead to ectopic gestation. Previous abortion, tubal endometriosis due to distortion of tubo-ovarian anatomy, adhesions, scarring, cicatrization, then it predisposes to ectopic. Cigarette smoking is again a strong risk factor which is associated with ectopic gestation. Diethyl stilbestrol exposure, which is very less common nowadays, and fibroids, which may obstruct cornual end, which may obstruct or distort tubo-ovarian anatomy. And sometimes there is transperitoneal migration of ovum from this ovary to this tube, thus there is delay and causes ectopic gestation. So ectopic pregnancy can present in 2 ways. One is acute, other is chronic. So acute ectopic pregnancy carries a classical clinical presentation. Patient will be having short period of amenorrhea between 5 to 8 weeks, and sometimes she must be coming, just has happened in this case, with just incidence of a spotting for 1 day or two. She might test herself and have a positive pregnancy test. There might be complaint of intermittent scanty vaginal bleeding, of dark blood or spotting, and she will have abdominal pain. There is a classic clinical triad of 3 A's, that is amenorrhea, abdominal pain, and abnormal vaginal bleeding. Now, this classical clinical triad of 3 A's is also present in abortions. But in abortion, there will be bleeding, which will be a predominant feature, and in ectopic pregnancy, pain will be predominant feature. But yes, these 3 A's will be there in both the kinds of problems in early pregnancy. Now, second presentation is chronic one, where patient might have recovered from previous attack of acute pain, and they usually give history कि एक दिन बहुत तेज pain हुआ था, फिर ठीक हो गया था. But patient will present with amenorrhea, dull aching lower abdominal pain, vaginal bleeding off and on, sometimes dysuria, frequency of micturition, or rarely retention of urine and rectal tenesmus because of the collection and hematoma formation inside the pouch of Douglas. So what do you do with such patients? As we have discussed, first is urine pregnancy test, and when you are an ultrasound, and when you are sure that you are dealing with a case of ectopic pregnancy, send her for other blood workup like CBC, viral markers, because you might need to be, operating her, and beta HCG. Special investigations, these are not actually investigations, but we'll discuss about culdocentesis, importance of magnetic resonance imaging, and dilatation and curettage in tomorrow's session. So beta HCG, urine pregnancy test, ELISA is extremely sensitive to even 10 to 50 milli international units and are positive in 95% of ectopic pregnancy. But remember, still 5% cases of ectopic pregnancy might report with no amenorrhea, and 7% of the ectopic pregnancy may have a negative urinary pregnancy test. So a high इंडेक्स ऑफ सस्पिशन कि ये जो पेशेंट है एक्टोपिक हो सकती है, सोच के हमेशा चलना है इन रिप्रोडक्टिव एज ग्रुप. Then we do a quantitative beta HCG, and along with transvaginal ultrasound, we discuss the discriminatory zones if the diagnosis is in doubt. Again, discriminatory zone will be discussed tomorrow. So what are the complications that can happen in such a pregnancy? Massive intraperitoneal bleeding leading to anemia. Sometimes when there is chronic ectopic, patient may form pelvic abscess, may have peritonitis, sepsis, DIC, rarely pulmonary embolism also. Sometimes there is massive rectal bleeding or rectal passage of fetal bones. Very few cases have been reported because of the rectal perforation. Maternal mortality was quite high, 4% to 29%, and it is still dwindling in the range of 7 to 11% nowadays also. And yes, we cannot talk about fetal salvage in such cases. So what are the options? So a broad overview. In case of acute ectopic, medical management is not warranted or considered. But in case of ectopic, which is not ruptured, that is unruptured ectopic pregnancy, we can think of medical management. And for undergraduates over here, the option for medical management right now that is professed and practiced the world over is methotrexate, given by intramuscular route. It is actually an anti-metabolite which inhibits folate reductase. That is why we have to give folinic acid rescue in such patient. So what is happening with methotrexate use? It is acting against actively dividing cells, and it does not differentiate between trophoblastic cells and normal active dividing cells of human body. So we must ensure that we are taking care of the side effects that this drug will produce inside the body of this lady. So methotrexate is given as 1 milligram per kg on day. You can learn either way, 0 to 4, 6 या फिर 1357, alternated by leucovorin injection as 0.1 milligram per kg, either on 0246 or 1357. So methotrexate एक दिन और leucovorin second day. Because of higher incidence of adverse effect and increased need of motivation and compliance, nowadays we are not using multiple dosage, and it has fallen almost out of favor. You must ensure that there are no contraindication to methotrexate like allergy, hypersensitivity, and renal function, liver function should also be normal. Now, exact criteria for medical management of unruptured ectopic pregnancy are: 1, your patient must be fully compliant and must be understanding the implications of medical management. Second, you must have obtained all the relevant consents and documented. Third is her serum beta HCG should be less than 3000 or 5000. That we'll discuss tomorrow, the updates. Then there should be no cardiac activity in the ectopic gestation. Then the size of the sac should be less than 3.5 centimeter or less than 5 centimeter. Again, we will discuss these points of contest tomorrow. And patient must be hemodynamically stable. If she is anemic, then blood should be transfused. Now, in case the need must arise, what are the types of surgical options you can give to your patient? In case of acute condition, laparotomy is generally preferred. Otherwise, in unruptured ectopic, laparoscopy is preferred, and we are doing quite many acute cases also, that is on surgeon's discretion, by laparoscopy nowadays. So what are the indications of surgery? Patient is not suitable for medical management or she has denied medical management. Second is you have given her medical therapy, but it has failed. Sometimes there is heterotopic pregnancy with a viable intrauterine pregnancy. Then you go for surgical removal of the ectopic gestation. Patient is hemodynamically unstable and needs immediate treatment as she has passed in shock. Now, contraindication of surgical treatment, exactly not contraindication, but where you will consider medical management is patient medically treatable, and otherwise a patient who is having very many medical conditions that precludes a surgical intervention in such a patient. But yes, if she's hemodynamically unstable, we have to take her up for surgery.
Recording in progress.
So laparoscopy is more appropriate in a stable situation because there is a very short operating time, less blood loss, shorter stay in hospital, and less need for analgesia, and the recovery is excellent and superb. And we discharge our patient the very next day. So there is one question about milking or fimbrial expression of ectopic gestation. Previously, there was a time where milking was done routinely. Then came a time where milking was abandoned and literature came कि milking नहीं करना है. But nowadays also milking has, it has come back again into the literature and evidence, but it is deemed only ideal in distal ampullary or infundibular pregnancy. However, still till date, it has got increased risk of persistent ectopic pregnancy. So milking या fimbrial expression should be done only in selected cases, especially जहाँ पे bilateral ectopic हो गया हो, या एक ऐसी पेशेंट है जिसमें ट्यूबल सैल्वेज इज वेरी इंपॉर्टेंट, उसका पहले से ही सैक्रिफाइस ट्यूब हो, या आपको लग रहा है कि बिल्कुल उस दूसरे ट्यूब में कोई जान नहीं है तो इसकी भी सेल्फ इंजेक्टमी कर देंगे, तो मे बी we should try to conserve tube, but weighing the consequences against having a repeat ectopic gestation later on or having a persistent ectopic pregnancy after this. So if you do a conservative surgery, weekly serum beta HCG is done till it is negative. And if we see that titer is increasing, methotrexate can be repeated. So the summary or key points for the only basic part of ectopic today is incidence of ectopic pregnancy is rising. And the causes are increased use of ART, increased maternal age, increased smoking, obesity, but maternal mortality from it is falling because we are detecting it earlier. We are having options of medical management. We are having other modalities of treatment also. Ectopic pregnancy can be diagnosed early also before it ruptures with the recent advances in immunoassay to detect serum beta HCG, high resolution ultrasounds, and maybe usage of diagnostic laparoscopy. There has been a shift in medical management from ablative surgery to conservative fertility preserving treatment in ectopic pregnancies. But yes, whenever there is a doubt and you don't know, maybe this is a case of PID also or something, anytime you are in doubt, laparotomy should be preferred. The choice of intervention is minimally invasive, that is laparoscopic treatment for unruptured ectopic pregnancy if medical management is not offered or chosen or is failing. But careful monitoring and proper counseling of patients is mandatory, and it should be educated to them that they need to, follow up or with you or with any other doctor. The documentation should be must and mandatory, and it should be instructed to the patient that she has to carry her medical records anytime she gets pregnant, and should be told to her treating physician that there was a history of ectopic pregnancy. Now, a question has come regarding the role of letrozole in pregnancy. Uh, I'll uh, I have prepared the entire lecture based on letrozole in ectopic pregnancy. And as I said earlier, tomorrow we will be talking about the updates and recent advances in treatment of ectopic pregnancy. And I am sure I will be having quite many surprising points for ectopic pregnancy because I myself, was learning quite a new things when I attended this seminar about ectopic. That was a roundtable discussion. So letrozole, yes, there is a role in ectopic gestation, and along with side effects that we'll be discussing tomorrow. And if there are any questions, please post in group, and I'll be posting a few questions after this lecture, and we can have a nice discussion maybe tonight and tomorrow. We're coming with updates in ectopic pregnancy management. And thank you so much to all for joining.